The the hip snapping patient.
Mm.
Um, Number one, have you seen him multiple times? I mean, I assume like you said, you checked his low back. I mean, was there
Mhm.
what do you this particular patient? Do you have any idea of kind of what you think is going on with him?
Well, I think that he had somehow um, gotten some weakness, probably from his back. This gentleman has some scoliosis, so the imbalances around the pelvis are can be significant
Okay.
and have to be managed. But however, in treating him, the low back had, I think, caused, from what I can remember, some weakness of the knee extensors. And in so doing, the psoas started helping the lower limb move forward. And over time, this assistance was not efficient and caused the psoas muscle to become hypertonic, because during his gait or his activities, the forward progression of the lower part of the leg was assisted by overuse of the proximal muscle groups to help carry the leg forward. And that was so the treatment was to release the psoas, treat the weakness of the lower, of the distal, the knee extensors, clear up their possible relationship to lumbar spine overload and so on,
Hmm.
and then start on restoring the length to the psoas and the tone normalizing of the psoas muscle. So I saw him for this. I think I've seen him 3 times, and we were able to have him on the third visit lower his leg without the click. So by finding out which exercises worked, not all exercises worked, we could give him 2 or 3 exercises that we're going to work towards eliminating that clicking function. And one of them, of course, as I said, included uh, um, adductor, reestablishing the adductors as part of that hip flexor extensor complex.
Okay.
Um, so, yeah.
Interesting. Yeah, that's a good. I mean, like you said, it's a good example of a snapping hip, particularly theoretically an asymptomatic snapping hip, is not a diagnosis in and of itself, and
Mm-mm.
how you start to kind of think about uh, that kind of presentation and how to go about managing it effectively and reasonably, so that you're not just, like you said, rubbing the psoas into oblivion or something like
Mm-hmm.
that,
Mm-hmm.
stretching it for the rest of your
And
life.
one thing that sometimes is not, that I learned from the years from, I think, Dr. Goodhart, was to look for example, the enthesopathy, irritation of the psoas at its attachment to the trochanter minor. Many people will not look for that. And because it is a pinpoint attachment, it can be strained, and the pull on that trochanter minor causes an irritation at that tendo-periosteal junction, and that will cause the psoas to become hypertonic. And no
Hmm.
amount of rubbing of the psoas muscle belly will release that. If it releases, it is temporary, and then as soon as the tendo-periosteal junction is pulled, it will go back to being hypertonic, because the
Hmm.
nociceptive input from that is so strong that you have to. So you often have to apply cross-friction massage to that area if you want to normalize the function of the ellipsoid muscle cells. So that is also part of being aware that muscle tone changes can come from the muscle belly or from the attachment points. And that if you treat the wrong end of the muscle, you will not really succeed permanently. You will end up just rubbing it over and over again. It will not heal. And that is true for many muscles. We have to treat either the muscle belly or the ends of the muscles if we can reach them. And that sometimes is a problem when the end of the muscle is inaccessible.
Well, sure. I mean, you're talking about trochanter minor, or the lesser trochanter, just simple practical getting in there. Some docs don't want to go there. Some patients don't necessarily want you going there. It's, in one sense, it's not deep, but it's deep in there, and it doesn't feel comfortable either.
No, it doesn't. It doesn't. But it is one of those things that has to be done, and I think
sure.
the
and you're just the guy to do it.
Well, the task is the task.
Yeah.
We take on we take a vow to do the best for our patients. So it's really that trounces any discussion as to whether you should or should not. It is what is best for the patient. I always try to let patients understand that this discomfort, first of all, is not of my doing.
Right. Yeah, you're not
pushing. You're not sympathize. Yeah, as much as I sympathize, the treatment is the treatment. If I had a nice version, I would apply it. If I don't, well, that's it. At least I'm not suggesting putting an acupuncture needle into your plantar fascia.
Those sadists. We're not those sadistic
I try to find nicer things to do. And in fact, I must say, on a personal note, I never do anything to a patient that I wouldn't do to myself. It really.
There you go.
Yeah. If I wouldn't have that done to me, I don't do it, because I think I'm very tolerable of pain. I am very logical in my thought process about it and unemotional. And I've experienced a lot of pain as a professional dancer, etc., etc. So being in sports, so I know what pain can feel like. So I'm not squeamish about it. So
I think I may have told you this little story about pain or this kind of thing, and I tell this to patients all the time while I'm doing it to them. If I'm really digging in or something is particularly tender, I tell them the story, which is true. Maybe 15 years ago, I was in Las Vegas with my brother and some guy friends, and we had a nice weekend. And my brother, in the middle of the weekend, ran down the hallway of a hotel with his hands along the side of the walls, and he cracked his thumbnail on the wall and just split his thumbnail. It was a bloody mess, but we had a good time in Las Vegas. He didn't feel a thing. After 36 hours, we get home, and his thumb was completely swollen. He started even having fever kind of symptoms. Take him to the immediate care center. Doc says, well, obviously this is swollen. This is infected. We need to drain this immediately. This is a problem. So they were just going to slice his thumb and squeeze out all the pus. And the doc said, well, we'll give you a topical anesthetic first, numb it. But the problem was his thumb was so swollen, the anesthetic couldn't get in. So he was feeling everything. And the doc said, well, too bad. It's so swollen. This is not a good thing. You're just going to have to turn your head, bite something, and deal with it.
Oh my God.
My brother said, upon the first squeeze of his thumb, it was so painful, he would have told Osama bin Laden where our parents were. So when I'm treating patients, I say, listen, I know it's tough, but if you're willing to tell bin Laden where your parents are, I'll back off a little bit. Other than that, we have plenty of room here. We've got leeway.
That sounds horrible.
Yeah.
That sounds horrible.
And,
Yeah,
when
my
patients
goodness.
laugh, and then,
Yeah.
so it's not hurting that so bad.
And then they scream.
Yeah. They say, then they tell me their mother's maiden name, and then I
That's right.
I let
And
off a
then
little
you
bit.
give up. That's right.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.